Hello, everyone. Welcome to our live Q&A session that concludes the end of day one of the 2022 ITP Support Association Convention. I'd just like to introduce a number of our ITP experts that we have to hand. We have medical advisor of the association, Dr. Gerard Provan, board member of the association, another medical advisor, Dr. Quentin Hill, another medical advisor, Dr. Nichola Kuter, another medical advisor who does the letter from America for us for the Platelet magazine, Dr. Neunert, and our Ireland medical advisor, all the way from near Dublin, Dr. Gerard Crotty, Dr. Vickie McDonald, who is also one of our medical advisors and runs the adult ITP registry, and all the way from America, our good friend and also friend of the PDSA, Dr. David Kuter. Welcome, everybody. I've got a number of questions that I'd like to put to you. I don't know who best to answer, but I'll just kick off. Got one from Caroline. She says, I've had low platelet counts for 20 plus years, and these range from in the teens, 19 to just over 100. I was never offered any treatment other than to monitor with regular blood tests and avoid aspirin. For many years, my levels sat at around 30, 35, and fatigue has been a persistent issue. I've been feeling exceptionally tired again. Blood work is all fine, except for platelet levels, which are 109, which is high for me. I try to exercise regularly, but will often feel worse after exercise and would take a day or two to recover. I was also wondering if hormone levels can affect platelet levels. I have noticed my platelets have increased on taking HRT. Now, I don't know who best. Shall I ask Nichola? Would you like to ask that one? And then you can pass it over to anyone else for comments.
Sure, I guess there's a lot of things around that. So a platelet count of 109 is fantastic. That's great from a risk of bleeding point of view. I think that the tiredness and fatigue is very frustrating and can be very difficult to manage. And I think that having a platelet count above 100 means really, I don't think it would be useful to have ITP treatment, because none of it is directed specifically to fatigue, even though we do know that some patients feel much better when their platelet counts are high. I think hormone changes, we probably do see changes in platelet counts at either end of a woman's sort of menstrual cycle, so teenagers and then menopause, I think probably does change platelet counts, although we don't fully understand it. But we clearly need to understand a bit more about fatigue and how that's associated with ITP and platelet count. I think that's answered a lot of the questions, or like that's some of my answers, I think.
Anyone else want to chip in with anything on that one? No? Okay.
I agree with Vickie. I think we were asked this in the adult session, weren't we, Dave, as well? Maybe by the same person, actually.
Okay.
And had said a similar thing that, you know, I think it is very hard with the fatigue, but when the platelets are over 100, it's difficult to know what's contributing exactly there. And often it is all the things that this patient's clearly doing with exercise and kind of focusing on the kind of mental well-being bits, but also looking for other things other than assuming it's ITP, that maybe just broadening and thinking about other things that might be coming into the fatigue as well, maybe having a chat with a primary care physician about that.
Okay. Thanks very much, Vickie.
Sorry, I was just going to back up what Vickie just said, because sometimes you pin everything on a disease because somebody has a chronic disease, and there are other things that people can get. So don't be fooled into thinking it's always the ITP that causes whatever problem. And as Vickie mentioned in her talk, psychological support would be really useful, because some of this may be depression as well and other things, which can cause fatigue.
I know in many of the patient support group meetings that we've held over the last 3-4 years, psychological support has always been raised, i.e. the lack of. And it was good to hear that, you know, there's some money actually coming out now, but, you know, will it be enough for the whole country? I don't think so. So, yeah. What's the situation like in Ireland, Gerard? with psychological support for patients?
I think on the public health service, it's fairly limited. The HSE has, relatively few. There is a primary care psychological service, but I don't know how accessible it would be for patients with relatively non-specific symptoms as opposed to more severe mental health problems. So generally, I think it is limited on the public health service. So of course, patients can, in some cases, source psychological support privately.
Okay, thank you very much, Gerard.
But I think people, the advice to seek the advice of your general practitioner would really be the main advice there, because it may, some of these symptoms, it's difficult to say, is it mainly psychological or is it physical? Is it related to the ITP or to other conditions? So I think the GP would be the first port of call.
Yeah,
we don't have GPs anymore, do we? In the United Kingdom, you can't see a GP.
I was actually had to go to hospital in an ambulance a couple of weeks ago, and we sat outside the A&E for an hour and a half. A nurse come onto the ambulance to give me an injection, take some bloods. A consultant come onto the ambulance, and both of them were saying, all these ambulances are here because there's no GPs.
No.
So it's frightening, absolutely frightening. But anyway. Just on the fatigue level question, I've got another question here from Maria. She says, my daughter is always complaining of feeling tired. She is very emotional and complains a lot about aches and pains in her joints and headaches. On both occasions when her platelets have gone up after virus issues, but all of this has gone away. In addition, her appetite goes through the roof, and she's obviously full of fun, energy and confidence. She is like a completely different child when her platelet levels increase. However, she's constantly being told that none of these are a symptom related to ITP. Now, this has come up loads of times where some healthcare professionals still don't believe that fatigue is a symptom of ITP. Anyone here? David?
Yeah, I think right now, not to sound unsympathetic, but fatigue is certainly part of ITP. That should be guaranteed, and everybody should know that. But number two, 80% of patients who go to physicians in the United States have fatigue as their number one complaint. So there are many other things that cause fatigue. So dissecting these things is important. If this patient who's being described right now was put on corticosteroids and a lot of other inflammatory things that can cause fatigue may be ameliorated, I'd just be curious to know what was a methodology by which the platelet count was raised and by how much. To me, there are patients, and I've blinded myself in patients with ITP to the platelet count, and there are patients, including if you give them a TPRA, their platelet count goes from 12,000 to 80,000. They feel like $1 million without knowing their platelet count. So
the fatigue question was the same. The level of patients saying fatigue's the number one was the same with the UK as well, with the I Wish survey. So exactly the same. Yeah. Someone else was saying something then?
I guess the question I posed to my colleagues is whether you would treat someone with a low platelet count, maybe over at 50,000, who's just complaining about fatigue. Would anyone ever treat someone like that just to see if the fatigue disappeared?
Good question. That's a no.
That's a challenge at 50,000, right? I mean, I think if you lower the count, we've certainly started therapies for quality of life reasons and fatigue reasons after you spend time talking with patients about what it is that is most troublesome to them. But we were even just having this discussion in our pediatric breakout group that we really lack the evidence that any therapies truly have an effect on the fatigue component, short of potentially increasing the platelet count. But even that doesn't necessarily correlate with, particularly once you're in the 50, 60, 70, 100,000, there's really no good correlation there between platelet count and fatigue symptoms either. So I think it's really challenging, but I do think it's good that there's sort of a movement in the community as a whole to include fatigue as an outcome in clinical trials so that we can start to maybe understand all this interplay. And I think that's really the best thing we can do for the patients.
What I mentioned to the last group that Vickie and I were talking to, the adult group, was that there are studies that have been done that have been analyzed, and I think that's the Vickie and Nikki both participate in this with our rules of written study. We did cognitive function testing on patients who got this drug before and after they got treated, and it's amazing the cognitive scores before therapy in ITP were dramatically low. This data will be analyzed and hopefully presented at ASH this coming year, but I was actually quite struck with the baseline pre-treatment values being incredibly low for cognitive function scores. So this goes back to other things that we can measure that may correlate with fatigue and other outcomes of quality of life.
So I agree with you. So we did, so that as part of the MRI study that we've done, we've also collected cognitive data. Wasn't correlated with microbleeds, but there was a really remarkable incidence of cognitive impairment that we saw in the adult patients. And I think for Cindy, for the children, I think we because children don't necessarily need to be treated, but I would treat children with lower counts than that, certainly if they're tired, just to see whether that makes a difference. And the impact on parents is huge as well, and that impacts on the children as well, I think.
And very clearly, parents can tell behavior changes in their toddlers. You know, even though a child can't express fatigue, the parents can very clearly. Or I have some younger children that do describe fatigue using their own words. And certainly that comes into our discussions when we're talking about reasons to start therapy, even in the absence of bleeding. We definitely focus on fatigue and quality of life. I do think, as everybody has said, though, the most important step is to rule out any other causes of fatigue while you're also going through the process of deciding if an ITP therapy would be helpful.
And I think recognizing it's important as well. As long as, agreeing with your patient that fatigue is a part of the disease.
Absolutely.
Makes a huge impact, I think. I think not feeling like your doctor doesn't listen to you, I think, can be really hard.
Yeah. I mean, if we start treating a patient with fatigue being the major outcome we're trying to do, we usually pose it as an experiment to the patient. We're going to try this for X months, see how you feel. And to my surprise, many people don't feel any better to plate at kind of 120,000. They do it 818. So I think right now, if you're going to do it, that's how I do it, as an experiment, not as a definite long-term treatment approach.
And I do think then too, it's a discussion about minimizing side effects of the therapies, right? You don't want to put a patient on a therapy that's going to have more side effects than the disruption of the fatigue. So I think it's a careful balance as well.
There's also the problem with fatigue being a fairly soft, sort of hard to measure thing, because some people are very stoical and they don't really report much fatigue, and other people like real prima donnas and go, oh my God, I'm so exhausted. I'm so exhausted, even though they're just minimally tired. I mean, it's not that we can measure it. We can't measure it in a tube or anything. So it's really hard to gauge whether someone really means fatigue or, I think
and Drew, as you well, in general, hematologists are in primary care position are incredibly insensitive to fatigue. For example, I have patients who have been iron deficient for 30 or 40 years with ferritins of 0, and they can hardly go to work. You give them the first dose of iron, and it's like putting water in a flower that's gone wilted. So there are situations where we are totally, as physicians, obtuse to the needs of patients from a fatigue point of view.
Absolutely.
Excellent.
So I mean, just to comment that we've done similar probably to Cindy and Dave, in that there are individuals who we've treated for predominantly fatigue symptoms where we wouldn't otherwise, where the platelet count's perhaps around the 20 to 30 mark. I don't think we've gone as high as 50. And none of those cases, I think, had a dramatic effect, if I'm honest. And most of them came off drug in the end. So, we do present that as exactly that as a discussion, and, we recognize that this might be effective for some people. But again, we've had a few who had lower platelets, responded very well to treatment and did feel much better. A comment would be that the one challenge with quality of life data is that there are so many points, which talks to the difficulty in measuring it. So if you take an SF36, which is a quality of life questionnaire that patients would fill in, there's many data points. There's many questions asked. So to sort of statistically model that against a small number of patients in a trial is very hard, and you end up with inconclusive data. And it feels like a lot of the studies are inconclusive in terms of positive impact of treatment. on.
I would say that almost all are not inconclusive. Okay, I can cite maybe 2 studies that had some positive variable. That other problem with the studies like that is you give them to patients in the waiting room for 30 minutes, and if you score the last 12 questions versus the first 12 questions, people just want to get it done. There's no data on the last 12. It's actually funny how you've got to make it short enough to be doable, and there isn't a good short form that does this.
And if you do the questionnaire before they have the blood draw,
That's right.
then the outcome is better than if you have a needle in the arm and then you do it, because people aren't so cheery.
Okay, thank you very much. Moving on to the next question. Danielle has asked, and this has come up a number of times at our patient meetings, is there any correlation between the low platelet count and a vitamin D deficiency? Who shall I go to? Drew.
Right. Well, I'm not aware of any major association, but we're just learning so much about vitamin D, and it's something we never measured before. Years ago, we never measured it, and we started spotting people being vitamin D deficient. I think the whole United Kingdom is vitamin D deficient. All our patients are, and I tell them all to take it routinely. It does so many different things that we're discovering. So I wouldn't be surprised if the platelet count and vitamin D level did correlate to an extent. And I have heard people say that when they take vitamin D, the platelets have gone up, but it's all very anecdotal and not terribly controlled. Dave will know if there's a study. He's the person that will know. No, he doesn't know.
There's no study, but I'd be very skeptical that it has I can't envisage a mechanism, but again.
Yeah, but I mean, it's involved in so many functions, isn't it?
Yeah.
I mean, it wouldn't be outrageous that it was involved somewhere.
So we have done a retrospective analysis of our patients. I don't think we can see any association between low vitamin D and platelet count, but I think people do feel better. So we always recommend people take vitamin D during the winter. And I think that, as you say, Drew, there's lots of associations with vitamin D. So reduced infection rates and just generally feeling a bit better in the UK, certainly when it's so dark. So I think we recommend it for people over the winter months, but people are really low. A lot of our patients, children and adults, have got really, really low levels.
Pretty much all of us live in areas where there's not a lot of sunshine. So in Boston, 85% of primary care patients evaluated in our recent study that the internists did were vitamin D deficient. And I mean, truly deficient.
Yeah. And I think, COVID probably didn't make that any better either. We had a period of time where people weren't leaving the house, weren't getting outside. So even in the summertime, I think there was a spike in that. People have looked at vitamin D and sickle cell disease as its anti-inflammatory properties, and I don't think much has come about there. But certainly to your point, I think people feel better with vitamin D replacement, whether or not it's affecting a chronic illness state or not, but just general, I think, balance,
Do they still put vitamin D in milk in the UK?
Not sure.
In Ireland, it's in some brands of milk.
Because that was forbidden in the United States about 8-10 years ago for a reason I don't understand, but basically it was taken out of all the milk dairy products, and the level of vitamin D deficiency has dramatically changed since that happened.
Well, your milk used to say vitamin D milk, didn't it? It used to have it on the label.
Because
I remember that from Boston. I remember that from Boston when I was there. I don't think we do.
And of course, even in the summer, we're more aware of the risk of skin cancer. So even when the sun is shining, we cover up and put on factor 50 sunblock. So we probably don't make enough vitamin D even in summer.
Superb. Okay, moving on. We've got a question just come in the chat. My 32-year-old son was diagnosed with ITP about 3 years ago. His count is on average around 40. Should he be offered any treatment? It doesn't quite seem himself, and he seems quite well, but doesn't seem to be himself. So should he be offered any treatment with a count of 40? Quentin?
So it sort of talks to what we're sort of chewing over. I mean, conventionally, no. you know, we generally don't treat patients, and particularly with a pandemic where immune suppression could do harm, with platelets more than 30, unless there's a clear indication. So the symptoms referred to are fairly non-specific, aren't they? So again,
yes, they are.
It's trying to tease that out a little bit and perhaps explore on an individual basis why we're not quite right. And, you know, one comment would be, you know, people worry about conditions. Again, the Quality of Life Survey said people worry about fatal bleeding a lot. You know, the lower the platelet count, the more the worries. So, you know, one question is, do we give enough patient information? Do we give enough reassurance that actually a serious bleed is a very rare event at that sort of platelet count? So, you know, there are things one can do to try and tease that out. But yeah, I think by and large, we wouldn't be thinking about treating at 40.
Okay. Any other comments on that? Yeah.
I would just tell the questioner that I saw a patient last Thursday for the first time who was diagnosed with ITP by a friend of all of ours, Gary Gilliland, at the Brigham Hospital in 1982, who's lived at a platelet count of 26,000 or to 30,000, has never checked it, has checked it infrequently for the last 40 years. He's climbed Mount Everest. He's done the Boston Marathon yearly. He's had 4 surgical procedures, to my surprise, with no bleeding, and has had platelet counts always at that level, but does have ITP. So
I know one of my friends had a platelet count of about 15 for about 10 or 15 years. And during that period, he never had any medication. He was fine. Yeah. So, okay. I've got another question here. This is about the, what is the recommended frequency for having your platelets checked? And if I just read the question out, I'd like to know how often platelets need to be checked, and does the timing differ according to what the level of the count is? For instance, how often would it be recommended to have platelets checked if someone had a count, say, between 30 and 50 or 40 and 60? Would it be advised to have them checked every month, 3 months, or what would be the best frequency? Vickie?
Yeah, so I think that the frequency of testing and monitoring and the closeness of monitoring does vary depending on what the platelet count is and how well the patient is and what treatment they're on, and whether the treatment also needs monitoring. So for somebody who had a platelet count at that level, so 30 to 50, 40 to 60, if they were a new diagnosis, I might be inclined to see them monthly for a blood count, mainly for reassurance and to get a feel of whether that platelet count is suddenly on the way down. But other than that, if someone was very stable in my clinic with a platelet count at that kind of level, without too many challenges, I wouldn't be seeing them more often than 3 monthly, I don't think. With some safety netting, they'd have a letter, they'd have the info to how to get in touch with us. I'd tell them what to look out for if things were going to change, what the kind of worrying thresholds might be, and what to do and when. So, you know, in hours, out of hours. But I wouldn't overburden people with visits and generate, because I think it does, when you're waiting for your count to come back and you know the appointment's coming, I think there's a bit of anxiety around that as well. And if you're doing that every month, that becomes a thing that I think is hard work to deal with. So I would be saying no more than 3 monthly, and possibly even pushing out further if it was really chronic and they'd had it a long time.
Understand, yeah. Any other comments on that one?
I would simply add that most of our patients who have long-standing ITP and are either on therapy or have come off it, we have an automated standing order for platelet counts they can have drawn at some local place should they experience symptoms of bleeding, such as blood blisters in the mouth, or if they're just worried because they have an infection and have previously dropped their blood counts. So if you put patients in charge of their own testing, this works well. The second thing I do is I give all my patients my phone number, so if they have questions, they can just call me.
Yeah, this is all about
that, actually, Mervyn. It depends on where you are, how advanced you are in this process, but certainly within the NHS system, depending on where this patient's followed up, some trusts now have a kind of, you can have a blood test done and then communicate via an app if you're tech savvy. We're not that far down the process yet for ITP at the Royal London, but I know we've been asked to start thinking about it as a trust-wide initiative. So there may also be some of those safety nets, depending on where you live, already built into your local system as well. I don't know whether, Nikki, Quentin, have you got that yet at Imperial?
Yeah, and I think that actually the other thing that you're saying is just if it's a stable count, just to try to reassure to say you really don't need regular platelet counts. People don't tend to change massively. So as you said at the beginning, regular blood tests is important, but after that, if there's no change in symptoms, there's no reason to do another blood test. And certainly the microbleed study that we did showed that you don't have microbleeds unless you have a very low count or unless you've got other symptoms. So there's no good reason to just do regular blood tests unless, you know, you're going to change something. So I think trying to reassure people really that if you've got a stable count, it will probably stay stable unless you've got other symptoms, I think.
Yeah, and giving control to the patient, I think, is really important. So it's great to sort of empower people to manage their disease actively. And I think that helps the psychology of it. So again, sort of saying, well, attend if you have a problem is very useful. So we have kind of an open access to our day unit that can ring up with symptoms and get a blood count usually within 24 hours.
I think I agree with Nikki. The thing is, if you see them 6 monthly, the chances of you finding the low count on that day when you see them in 6 months, it's not going to happen. It's going to happen in between appointments. They're going to relapse. So as long as they know what to do when they see TKI or bruising, that's the critical thing, as Vickie said, giving out information, the hotline to who you need to see and what you need to do.
Great stuff. Thank you very much for that. Got another one here. Again, it's on regarding Revlade, L-Trombopac and the leaflets. Catherine says there's warnings precautions on the Revlade package leaflet that refers to cataracts and regular testing. What frequency, it's again going back to the previous question, what frequency would you recommend for a 17-year-old with an average platelet level of 45? As it's Revlade, American branding. David?
Well, we call it Promacta, so I should avoid. So I mean, I think this cataract thing is nonsense. It's been disproven in ITP patients, and it's been studied, and it's an irrelevancy for care of patient ITP who are taking Revlade. I wouldn't even bother with it unless you already have cataracts for some other reason, like excessive steroids.
But the reason for it, sorry, Dave, the reason for it was the regulators.
I know.
Because of the animal studies way back.
But there are 3 human studies where cataracts were studied.
Absolutely,
Prospectively, it showed no effect, and that should be things get on the package insert and then never taken off. Yeah, and this one should be well off the package insert.
And that actually the other things, so the age of the person, the amount of steroids they're having are other things that are more problematic. We don't do regular eye testing at all.
70-year-olds do get cataracts.
The other thing I remember from reviewing that data, though, the cataract data, was that it's really difficult. It's actually not that easy to detect early cataracts either. So I don't think it makes a difference. If you have symptoms or if you're concerned about cataracts, you need to see a doctor, irrespective of what drugs you're on, I think.
But if you do detect it, Nikki, how do you prove it's L-Trombopac?
Yeah.
I mean, it's more likely not to be L-Trombopac.
Sometimes it's positive, sometimes it's negative, so I think just if you're having visual disturbance, then you need to see someone, but otherwise I don't think there's a reason to do it routinely.
These are rarely things that pop up overnight. These are things that take many years or even longer to evolve.
I will say to your point about the package insert, the problem with once it being on there is, we try to, even opening a pediatric trial with L-Trombopac, we spent a lot of time trying to say we absolutely don't have to put all these children through a screening exam for cataracts. And it took a while to not have that have to be written into our study protocol. So it really can be damaging when things get in a package insert and then don't get reviewed again and are just kind of left there to sit.
Well, not to spend too much time on package inserts. There's a lot of disinformation in the package insert, such as the simple statement, discontinue if platelet counts too high, because in our studies with these drugs, a week later, half the patients had platelet counts that are below 10,000. So you've got to be very careful when you're reading these package inserts as a patient, as you discuss it with your hematologist.
Okay. Thank you very much.
Let's trash the companies more, okay?
I know somebody's package inserts. FDA,
right?
I know somebody's package inserts are the size of our encyclopedia, but anyway, let's not go there. Andre in the chat, interesting one is, someone with ITP could processed foods be one of the causes for fatigue? I've never heard this one before, but is it possible? Cindy?
So I think, obviously, as we've talked about, looking at other sources for fatigue, right? I don't think I know of any data in the general practitioner world about processed foods and linking to fatigue, but certainly I think for everybody, the more balanced, healthy diet you have, probably the better you're going to feel overall. We have an open survey just looking at complementary therapies that patients are using for ITP, because that does come up quite a bit. And with regards to diet, maybe not so much processed foods, but the role of like an anti-inflammatory diet, of which there, is information about how to have an anti-inflammatory diet. I don't think we really know. And I'm always happy to assist patients in whatever they want to try, as long as I feel like it's safe and is going to work well with the other therapies that we're doing. And we kind of use it hand in hand with medical discussions and medical therapies. We are fortunate in our group, we have an integrative therapies team. So if somebody is interested in alternative therapies, diet, we can refer them to that team. There's also some work being done. Michelle Lambert at CHOP, and this was one of the PDSA grants, was looking at the microbiome of the gut. And there's been a lot of attention placed on the microbiome, the gut microbiome, and the role of inflammation. But I think, again, we don't have that data out there yet. But there are people looking at the role of diet and inflammation and gut microbiome. So I don't know if anybody else has more insight, but that's just my general thought.
Nichola, was you going to say something then?
Oh no, I think my email just pinged. No, I mean, I guess I agree with Cindy. I think that one of the things we do is just try and work with people. I think it's really important for patients to be able to try to get some control over their disease. And so if they want to try different diets, we're very much on board with that. And I think some people do like to try elimination diets or other things. And there's so little we understand about autoimmunity. That as long as it's safe and done in a measured way, I think that's sensible. I think certainly avoiding processed foods and eating lots of healthy fruit and fiber is a really crucial part of staying well and staying fit and healthy. Drew can tell us all about exercise and the importance of exercise.
No, exercise is good. No, exercise good. Especially if you lift resistance training everyone should do it. Dave should. Maybe Dave does it. I don't know. But
6 miles a day of walking, Drew, is all I do.
Oh, okay? Walking.
Sorry.
Yeah, but you need to lift some weights as well, though, Dave, for your bones and things, for your spine.
I drink the glass of wine every night. So stress.
Okay.
Okay. If I could just speak to our audience rather than being glib here, is that one of the things about statements we're making is that we don't know whether diet has any effect upon autoimmunity. What's really interesting is the microbiome is a really hot topic for a whole bunch of things. We just published a paper showing the microbiome can predict cardiac disease of certain types versus, people don't have coronary disease. So this is a really interesting topic that we may 5 years from now spend the whole hour talking about what's good to eat and what's bad to eat. So as much as we might dismiss processed food, which is a good idea, it's an interesting topic that is being explored.
Dave, can you tell the audience what testing the microbiome might mean? What is that? Is that something down your throat? Is it something
there's a whole panel of things you can test for that are beyond my skill set. There's a whole analysis of this anaerobic pathway that, again, I'll send you the papers, Drew, but
okay,
it is not standardized testing. Is probably the best thing to say. Cindy, you're nodding.
Yeah, no, we there's a lot of work at our center looking at it with the bone marrow transplant and changes. People have looked at chronic antibiotic use with sickle cell patients and the changes. I agree that I think it's going to be a huge topic of which we're going to learn. And to Drew's point as well, and Nicholas, I think there is some fatigue data that does say, there is conditioning and you can recondition. There's a lot of work on sort of slowly, incrementally increasing activity and increasing exercise and actually finding that that does help to combat fatigue. So as much as you're feeling tired to go for a walk, if you go for a walk, you gain energy instead of the opposite of which you might think you're going to just feel exhausted. So, and I would suspect, as Vickie pointed out, the same is true for diet, right? I mean, the healthier the diet, I just think the better overall all of us feel, whether we have ITP related fatigue or not.
Was there a study done a few years ago? I believe he's retired now, Professor Hunter at Cambridge.
It was sponsored by the UK ITP Sports Association.
It was, yes, yeah.
Who funded
100,000, yeah.
And I think the net result was he found nothing of any great consequence. So it's a Cambridge study, wasn't it?
That's right, that's correct, yeah.
The antibodies were negative, but there are changes in the microbiome. I think it's a really hard topic to study, and that was something done about 5 or 6 years ago when actually the microbiome was not quite so sophisticated. Yeah. So I think they did find some changes there, but it does need to be done with a really good groups to do that, I think.
I remember he presented at one of the early conventions that I attended. So yeah. So fine, it's okay. Let's look at the time. One last question, and John Granger actually answered this on the chat, and I've actually emailed the mother as well. But I said to John I was going to put it to the panel because there may well be other parents watching this who would like to know the answer. And it's from Gillian, and she wanted to ask her 2-year-old, who was diagnosed on her 2nd birthday last September with ITP and has had subsequent drops since. The lowest is to 9,000. She doesn't always present with a petechiae rash, but they discovered very low counts. She is very irritable, doesn't want to walk, says her legs hurt, and often gets very dark bruising under the eyes, like she has black eyes. Sometimes the eyes come on quickly, and the GP says there's no infection, so not sure what it is. Could it be linked to ITP, as it sometimes happens when we think she is okay? They also confirmed Raynaud's pneumonia, and I wonder if the leg pain and irritability is connected, and also the under eye bruising to ITP. So, Nichola?
I think it's really hard, isn't it? It's very hard to answer those questions without seeing someone. I think there's so many different reasons that you can have all of those symptoms. Certainly, I think for some kids, when their platelet counts drop, I think they can become more irritable and more tired. And it's important to closely monitor that and see how much that impacts really on the child and on the ITP. And sometimes we do make decisions to treat if there's really a significant impact on how they are really. And I think reassuringly, unless the count's very low, there's no serious problems on that. But I think it's definitely a dialogue you need to continue to have with your clinician about at what stage is it a good idea to treat. And I think the anxiety that's around children with low platelet counts and anxiety around how irritable they are, I think that's a really difficult topic, I think. And talking back to sort of just be able to feel trust in your clinicians and the whole team looking after you, I think is a really crucial thing with that. And some of the things we've done has involved play specialists as well, talking to children and sort of really trying to work out what the problems are and where the irritabilities come from. Cindy, I don't know if you have also have
no, I think that all is, it's always hard when you have children with ITP that also have other symptoms and you're trying to tease out what may be representative of either not straightforward ITP versus something physiologic about the ITP, such as fatigue, versus is this behavioral change because of lots and lots of frequent visits to the physician, all of that disruptive to the daily life of a child. Also, some children, I think, can be very reactive to just even that disruptiveness. So sometimes just even talking about maybe reducing frequency of visits, if that's something that's occurring really frequently, can help with that anxiety and also with the child feeling a little less anxiety over having to always go to the doctor's office, which sometimes can be a component. But it is true. We were saying earlier in our children's group, children can experience and express fatigue. I mean, one of my patients either described himself as he said, I'm either a sleeping leopard because he would be tired with lots of bruises, or he'd come in and say, I'm a lion, today I'm a lion. Yeah. And sure enough, he was kind of predicting his platelet counts. He said, no, they're not good. I'm a sleepy leopard. So they can feel it. And so I agree with Nichola that the change could be related just to simply the low counts, but it's important to really tease out what else might be going on. And then also making sure that this, again, we've been talking a lot about making sure that any other symptom is truly not an indication of something else going on that is unrelated to the ITP.
Black eyes is interesting. If a child's got a very low count and they're rubbing their eyes quite hard, could that bruise? Would that be possible?
I think it's hard to know without seeing a picture of what the dark eyes look like. I think some even children are very sensitive to sort of a discoloration that's just from, and again, that can be related to being tired and being fatigued and kind of getting discoloration and poor sleep versus truly being a bruising phenomenon. And if they come and go, that's less worrisome than if it's truly like a standing, kind of very, very dark appearance to under the eyes, which is a different symptom altogether.
And I think the other thing I would say as well is that I think for children, when they go through a period of having ITP, they may well be tired and irritable, but it's not dangerous. And actually, most kids do still get better. And so actually just trying to not being stressed and anxious about that, because it's not dangerous. If the counts are okay, there's not significant bleeding and bruising, it's frustrating and it's difficult, but usually it's still it's still a period of time that might feel like a very long time, but it's still actually just a period of life. And as we were talking earlier, we don't really have treatments for fatigue. So it may be just a period of sort of watching, just having a less stressful lifestyle, and just, as you said, actually, Cindy, not going to the hospital quite so much for blood draws, because if there's no bleeding, there's no indication to treat. It's like having a virus that you're recovering from, and it takes a long time, but you almost always does get better with kids. And I think those sort of dark circles under the eyes, all of sort of skin color changes, we see a lot, and with sort of low platelet counts. But again, it's not dangerous, it's frustrating and it's irritating, but it's not dangerous, and it usually is short-lived. So I think those are the things that
Thank you very much, Nichola. Thank you. Well, I think at that stage, just after 5 o'clock, we'll wrap it up now. Thank you to our panel. And I've had a message from Adrian. He says, thank you very much for supporting us and doing this panel today. It's gone really well. So thank you. To all the people watching, just thank you for attending day one of the United Kingdom and Ireland ITP Support Association Convention. We are looking forward to welcoming you back tomorrow. The lounges and exhibit hall will be open from 10 o'clock in the morning, and the first introductions and talks will begin at 11. Also, remember, you will be able to catch up with most of day one's presentations a bit later by clicking on the auditorium tab and scrolling down to the agenda and Saturday's presentations, then just click on the watch video button. Thank you again. I look forward to welcoming you back tomorrow. Thank you.
Bye. Thank you. Bye.